Um, so I was asked actually to talk specifically about how AI has evolved, especially in medicine, although, of course, the medical AI is all tied up with AI in general, because medical AIs, as I'll be describing, started at about the same time. Um, so we'll talk about the roots, the evolution, and then a little bit about what all this says about the future and what we'll be expecting to come next. Um, I think you've all probably played around with the various AI generation of images capabilities. I find this to be fascinating, and I thought that as a demonstration, I would try to prepare an image using one of the large language models that does image generation, and I asked it to draw a picture of 5 to 7 technologists who were taking notes while watching a presentation on medical AI. And uh, I was pretty blown away by but that's the picture that was produced for me. Apparently, those are all make believe people, and but it figured out what medical AI was, and it showed a potential first slide, and the whole business. It's a real grasp of the field and what such a talk might be about. And many people today are just viewing this kind of thing as almost like magic. How in the world did we suddenly develop these kinds of capabilities? Um, so I'm guessing that the history of image generation by artificial intelligence is not well known to most people. So I thought I'd start with just a little bit of an example of how long this kind of work had to go on before we got to the capabilities that we have today. Um, and so let me tell you about Harold Cohen, uh, a pretty well-known painter from the UK, born 100 years ago and very active until about a decade ago. Uh, but at some point in his life, probably when he was in his late 20s or early 30s, he became convinced that the most interesting thing about painting was what went on in his head when he produced a drawing or a picture. And so he actually picked up and moved to the United States to go to Stanford University and the University of California in San Diego, where there were significant early artificial intelligence efforts underway. And what he wanted to do was see if he could become sufficiently knowledgeable about how to write software that he could write programs that would capture the way in which he drew paintings and then would draw paintings on its own. The software would, perhaps with some directions about what should be drawn. So the program he developed, which evolved over many decades, was called Aaron, Aaron, a name. And when he started, he would have the software actually draw the picture using a kind of robot machine that would do drawing. No color was available in the early days. So instead, he would paint the color after he got the drawing out of the computer. But when he started it going, he had no idea what it would paint because there was a creative aspect and a heuristic process going on that meant that he was mostly just having it draw using what he in his head had thought about what he would do and then encoding it in the program. So here's a very early example of the kind of drawings that were produced by Aaron. This was one he painted the color to add the color. It came out just as a kind of unusual set of figures, all as one painting that he then painted and showed to people. And people were fascinated that some computer program was creating this spontaneously based on what he told it were his ideas for creative work in art and painting. It got better later. He taught it about human anatomy and it could draw pictures of people. Here's an example from some years later where the human figure was part of the painting. a plant. The coloring by this time was actually done by the program. He didn't need to paint them anymore. And over time, they got even more complex. Whole uh, uh, floral arrangements such as this one produced by the program. And to him, the fun was when he started the program running, he might give a few guidelines about the kind of picture he wanted, but the actual painting was created by the program. And this kind of work became very famous. Harold Cohen became well known. And in fact, just last year, after about 8 years after his death, they had a retrospective art exhibit at the Whitney Museum, a major art museum in New York City, um, uh, uh, basically for about 3 months, where you could go and see his work and even see Aaron produce some pictures on the fly. Uh, I went to this exhibit and I said, I bet a lot of people who are interested in AI have no idea that this kind of early work is the kind of work that led to what we now take for granted with image generation from AI programs. That's the device that draws some of these pictures that you see on the right. It was, by the time they had it running at the museum, it was running off of a iMac or a MacBook Pro. And so it didn't take the huge computers that he had to use in the early days when he was doing this. All right, so with that background, I'd like to give you a sense of how the field has evolved, especially with an emphasis on medicine. There's really a 60-year history to medical AI. Give you a bit of a sense of the unique challenges that medicine offers that have advanced AI itself, because medicine has been a particularly hard area in which to produce some of these programs. And some of the work has reflected back on the more general applications of AI. And then try to close with some assessment of the promise and the valid concerns that exist today about how AI can and should be used in medicine. There are clearly some threats and ethical concerns and real concerns about how best to evaluate and feel comfortable using these kinds of tools. So usually when people talk about artificial intelligence, the first time that word was used was in about 1956 at a meeting held at Dartmouth College in the US. And the name was coined by John McCarthy, who went on to become a very famous AI professor, not in medicine, but generically in medical AI, in AI. So that's arguably when at least the term artificial intelligence first began to be used. Of course, some of the concepts predated that. And many people would point at Alan Turing and what happened during World War II as being some of the earliest stimulation to developing these kind of computational tools. And then people say, yeah, but we've just done machine learning recently, right? I mean, suddenly machine learning hit and that made all the difference. But no, machine learning was around since at least 1959. This is a fellow named Arthur Samuel, who worked for IBM Research and got interested in how he could get a computer to play a complex game such as checkers. That may not seem very complex, but actually checkers by computer didn't exist at that time. And he began to play against a program that he had written. He began to realize the program was learning from the experience of playing with him, because he had a scoring function for different board positions. And so ultimately he decided maybe he should just have the program play against itself, because he wasn't a big expert on checkers. So he got two computers, which in those days was a big deal, but you could do it if you worked for IBM Research, and he had them playing against one another and for hours at a time. And eventually the program was so fine-tuned with its scoring function that the world checkers champion couldn't beat it. It was the best checker playing entity in the world. So that got the idea of machine learning going, but I'm going to talk a bit about why it took so long for it to have the kind of impact that it's had in the last decade or so. I would say that in the 1960s, AI really began to be recognized. And there were three principal universities in the United States. And frankly, most of the work in AI was in the US at that time. Uh, at Carnegie Mellon University, Herb Simon, a Nobel laureate in economics later, but a psychologist and economist, got very interested in human problem solving. And he worked with Alan Newell, also a psychologist, and defined the AI programs that evolved out of Carnegie Mellon. Marvin Minsky at MIT, where John McCarthy had been, but John McCarthy moved to Stanford in the mid 60s, and he essentially led the AI efforts in those early days at Stanford. Now, I was in the 1960s, I was went in university, going to university at Harvard, and I got intrigued by computing and decided I would go to one of the few medical schools that would allow me to study both computer science and medicine. And that was Stanford University. So I did go to Stanford and found that there was a lot of fascinating work on AI going on there, work that I had not encountered back at Harvard. There was early work going on at machine learning and neural networks, which were the original approach to machine learning, or called perceptrons in the very first books on the subject. Efforts to try to understand natural language when it was typed in and get appropriate question answering back from systems. And even speech understanding, which was much harder than language processing because you had to interpret the signal from a microphone of someone's speech. Simulating human problem solving, which is what really intrigued me, and even some early robotics. But it was during this same period then that AI in medicine began to evolve, most of which were what became known as knowledge-based systems or expert systems. In fact, if you look at a definition of AI in an AI textbook in the early 1980s, the emphasis is totally upon acquiring and applying knowledge. This is Patrick Winston's textbook definition of AI. And I think you'd find a very different definition today because of how differently the field has evolved from this early notion. But basically, this is still the motivation for everything going on: how to manipulate and communicate ideas, how to acquire knowledge, how to apply it properly, how to reason symbolically, not always mathematically. So I was very fortunate to arrive at Stanford at a time when there was already a major biomedical project underway. It was led by the people I put on this slide. Some of their names will be familiar to you. Joshua Lederberg was the head of genetics at Stanford. He'd already won the Nobel Prize in medicine at age 33. He was an amazing, brilliant man. Went on to become the president of Rockefeller University in later years. Carl Djerassi, who was an organic chemist on the Stanford faculty, who had invented birth control pills and was involved in starting the first companies that commercialized birth control pills. And then two people who are still alive today: Ed Feigenbaum, who at 90 is still very active, and Bruce Buchanan, who became my closest colleague. And much of what I'm describing here is due to the collaborations I had with Bruce over many years. So by the 1970s, we began to see the first set of programs that got a lot of attention, including in the press, but mostly in journals and the like, that all were focused on medical decision-making support. The internist program, which diagnosed internal medicine diseases and neurologic diseases, that was developed at the University of Pittsburgh. A program called CASNet from Rutgers University in New Jersey that worked on causal modeling with a focus on glaucoma and the physiology of the eye. My work at Stanford, this was my PhD dissertation work that we called MYCIN. I'll tell you a bit more about that. And a program called the Present Illness Program, or PIP, which was developed at MIT and Tufts University Medical Center. And it worked at actually taking a patient's history and modeling the reasoning that went on in the physician's head when they asked questions and hypothesized about potential explanations for a patient's problems. The methods that were developed by these 4 programs were generically useful and then ended up being applied broadly outside of medicine as well. So the MISA program that I worked on, I'll use as an example, partly because I know it well, but it's pretty easy to understand as well. This was a program that we wrote to try to help a clinician decide on the right antibiotics to give for a patient with a serious infection before you knew the culture results, before you knew exactly what bacteria were causing the problem. And you needed to cover for all the possible explanations for their infection. There was an engine that could be used to give advice based on rules that we use to encode the knowledge of this domain. And because the rules could be translated into English, we could even generate explanations for users about how the program was reaching its conclusions and its final recommendation. So the book version of the dissertation is available for free download, and you're welcome to take a look at it if you'd like to see the work in those early days. The basic idea was to separate the knowledge in a corpus of decision rules from the actual program, a consultation system that gave advice, an explanation system that explained the advice, and even a rule acquisition system that tried to allow experts to teach new rules to the system after they used the explanation to debug a consultation that they felt was not wholly adequate. The information about patients had to be entered by physicians. And of course, the consultation system kept a constant record of what it was doing, and that was used by the explanation system to explain what it did. So what do I mean by this? The key notion is to notice knowledge in a corpus of decision rules and an explanation capability that could convert those decision rules into English language statements that a clinician could understand. So internally, all of this work was done in the Lisp programming language. And this is an example of a rule. You can probably almost figure out what it says, but it was easy to write software that would convert it into a simple English language version. And so what that rule was saying is that if you know that you have a gram-positive organization under the microscope and it looks like cocci and they're growing in clumps, then this is a very simple rule, I might say. There's evidence, not absolute certain evidence, that the identity of the organism is Staphylococcus. Excuse me. The number here was called the certainty factor. There's a whole literature based on how certainty factors were defined. I won't have time to talk about them today, but one of the points about medicine is you're often dealing with uncertainty, and we needed a model for how to do that. And there's a lot of explanation for why classical probability theory or Bayesian statistics was not used. Our intuition, and I was a medical student as well as a PhD student, was that physicians wouldn't want to use a program like this unless it could give advice. But we finally decided we would do a formal study of this and published a paper back in 1981 that analyzed what physicians told us. We had a whole bunch of captive physicians at a conference that we offered, and they all filled out an evaluation form in which we asked them about what they would require before they would want to use one of these kinds of systems. And we found that when we ranked their responses, this is in order of importance. The most important thing the physician said was that the program should be able to explain their diagnostic and treatment decisions to physician users. And note that it also said it should display an understanding of its medical knowledge. If I'm going to use it, I want to know that the computer really gets it. They should display common sense. They should simulate physicians' thought processes as much as possible. So these became kind of guiding lights, these kinds of observations for how we should build AI systems that physicians would actually be willing to use. Remember, this was at a time when programs tended to be standalone. You'd have to care enough to go and actually use the program to get advice. It wouldn't be integrated with anything else you were doing because, frankly, computers weren't used much by physicians at that time. So what's an explanation look like? Well, the computer during the consultation would ask you questions. Do you feel that a significant number of organisms were obtained? And instead of saying yes or no, you could say, why are you asking me this? And so you could type why. And if you did, that would be essentially saying, why do you want to know whether a significant number of organisms was obtained? And it would give the rule that it was considering at the time, which is trying to conclude whether or not there's a significant number of bugs. And it says, that's because I'm trying to find out whether there's a therapeutically significant disease associated with this occurrence of the organism. Well, you could say, why? Why do you want to know that? So you can ask why again. And it would give you the next rule in the chain that was motivating the first question and give you a sense of the chain of reasoning that was being followed by the program as it generated questions and gathered data. So at this time, we're now talking about late 70s, early 80s, it was a common perspective that clinicians would use AI systems if the programs could be shown to function at the level of experts. And that meant that we had to study and simulate how experts in the field reasoned, and experts in infectious diseases were very much a part of the work we did in developing mycin. And then you had to use expert performance to actually benchmark the system to see how the program compared with experts if they were confronted with the same questions. And that meant you needed to do formal evaluations. And so we took that seriously, and in 1979 published an article in the Journal of the American Medical Association, which showed a blinded evaluation that we did. When I say blinded, it means that the recommendations that were being compared included mycin, but also several other recommendations that came from infectious disease practitioners, medical students, residents, infectious disease fellows, and the like. And the bottom line is that if you look here, 8 independent evaluators looked at the management of meningitis, comparing mycin's choice of antimicrobials with the choices of 9 other human prescribers. So there were 10 test cases, and mycin received the highest acceptability rating in this blinded study. So we felt that was optimistic, positive, but isn't it interesting that even experts in the field were not evaluated at higher than 65%? So a lot of work went into thinking about how human beings reason at the time. There was a lot of overlap with cognitive science. There were books on medical problem solving, such as the one I've shown in this picture. And the intersection of psychology with computer science became more and more clear as AI evolved, and with an emphasis in medicine on reasoning under uncertainty. This is a quote from Ed Feigenbaum, who really defined the notion that knowledge is the power of these programs, not their reasoning method. And there's a quotation that you can read yourself that became one of the mantras in the field at the time. Feigenbaum was also an excellent promoter of the field. He was asked a lot by companies whether or not they should be investing in this area, and many companies began to create AI groups. This is now well into the 80s when this began to happen. The cover stories in leading magazines and newspapers tended to be very positive. They talked about how AI was going to change the world. And there was accordingly investment by companies in learning about AI and creating research groups within their own companies. The problem is it was hard and there were limitations. So there began to be disappointment by the late 1980s that applied AI was really not becoming practical or living up to its press predictions. The press really was over optimistic about how quickly AI would have an impact on companies. There was a perceived overselling of artificial intelligence, too much hype, and people who were seeking research grants had to stop using the word AI if they wanted to get funded because it was falling out of disfavor. So this period is often referred to as an AI winter, a period during which AI was out of favor. Let me add as a comment here that throughout the late 70s and 80s, AI was definitely no longer limited to the United States. There was lots going on in Europe and in Asia, especially in Japan, where there was huge interest in it. The so-called fifth generation project, which was all about AI, was big in Japan. So what had started in the US became essentially worldwide, at least in the developed world. There had been a little AI winter that didn't really affect us in medicine much because medicine was just getting going at the time in the field of AI. But this is about interest and enthusiasm and the dates across the bottom. And so basically, since about 1993, we haven't had a downturn, another AI winter. So things have gone better subsequently. In fact, the interest in computing has thrived. There are positive views on the future of computing that were reflected in the 90s in major magazine stories. There's a very young Bill Gates, obviously, when Microsoft was just getting going. So I like to point out to students who don't realize just how palsied the environment was that we had to work with in the 1970s and 80s compared to today, because the technology has evolved remarkably in ways that if we had had this available, we would have done everything we did quite a bit differently. So first, networking. There was a very early version of the internet called the ARPANET that we did happen to use at Stanford and at some of the other medical AI groups, but it was not yet a commercial phenomenon. It wasn't available to everybody. And there was no domain system yet until about 1990. So the internet and what it allowed us to do in combining data and accessing data sets and the like was a crucial part of the evolution. There were no personal computers until the 80s, and graphical interfaces of the sort that we have come to take for granted didn't exist. Everything you saw in those Mycin examples was on typewriter type terminals. Memory shrank. We have high density memory chips compared to the 70s and 80s. Mobile phones didn't really appear till the 1990s. And the speed of computer processing, this is a exponential scale called Moore's law, which shows how much faster at an exponential level computers have become over these years, and even more so once we had graphical processors, GPUs, to handle the computing requirements. So that's all part of the explanation for why we're in a very different world today where AI is concerned. Then there's the evolution of the methods that use those various technologies. Suddenly we had huge databases and could put them into reasonably sized computers. We began to see machine learning become a reasonable goal compared to in those periods where early machine learning in the 70s, 80s, and even early 90s was still pretty stymied by the limitations of the technology. The development of a whole field called data science, which focused much more on data than knowledge, and recognized that some knowledge could be basically generated from processing huge amounts of data. There was the ability to do computing in the cloud and not have to do everything on your own personal computer. So a lot of this sort of uploading of data sets, analyzing them via the internet, and cloud computing opportunities that were out there. We saw much more formal development of terminologies for domains. Medicine drove a lot of this, the so-called ontologies that became crucial to the subsequent ability to reason about relationships in particular. Speech understanding really did take off. I mean, it would have been a pipe dream to think we would ever have a device in our hand that could understand what we speak into it and act accordingly. But we now take this totally for granted. And then after the turn of the century, the development of deep learning. I'll say a little bit more about that in a moment. But this ability to suddenly have neural nets that no longer were constrained by how many layers of computation could be included between the input and the output layers became really important to a lot of what we've done, especially in the area of image processing earlier than other areas of medicine. And then large language models, which we're all fascinated with and have developed in the last few years, but build on these other technologies. And then in medicine, the evolution has just evolved tremendously. The key, of course, has been the development of electronic health records. Suddenly we had data that we could access and not require physicians necessarily to sit down and interact with a computer or enter in data themselves if they wanted advice. The biological world began to discover the importance of computational biology, and then public health began to build on it tremendously as well. Imaging was the first to really take off. So the days of mylar film in your hand to put up on a viewing box are gone, and everything is essentially digital these days. And now we have medical specific chatbots. So with all those changes outside of medical AI itself, of course, can be a very different field now than it was before these changes occurred. These changes, everything I just described, has occurred since 1990. This is the way we used to keep medical data, right? Those of you who've worked in medicine for more than 20 or 30 years remember big rooms filled with records like this. How are you going to analyze these to learn anything other than by hand coding and the like? Well, that all changed with the electronic health record. So today you don't find record rooms like that in hospitals anymore. In most places, you might in a few places, but in general, you do not. Even private offices have largely gone computational. So this has resulted in large amounts of digital patient data, including images, which we can now merge with other kinds of lab results and observations by clinicians. And that's allowed us to develop new capabilities, especially due to the visionary work of the people who developed and demonstrated deep learning methods with an emphasis on medicine, even in that early work, resulting in last year's or 2 years ago Nobel Prize, for example. So the recognition of the importance of that kind of work to what we're able to do computationally in medicine today is clear. And now today, we literally have an opportunity to learn from millions of cases rather than the much more palsied approaches that were available to us in the past. So by the the first century, first decade of the new century, suddenly the news magazines were really focusing on medical issues in the technology much more, especially because of imaging and electronic health records. So that's kind of where we got to where we were 20 years ago. And at this point, and Stefan, I'll let you tell me, I can answer some questions about this history, but I do have more to say about what's going on now and what lies ahead. I'm guessing that nobody has anything to ask right now. Okay. Feel free.
Yeah, let's continue, I would say.
All right. Stefan had said this might be a good place to pause in case there were questions, but we will go on from here. Okay. So today I would say that you can, in the area of clinical decision support, which is really what has driven medical AI, there are three basic categories of clinical decision support. At least that's how I see it. One is what I would call computational support for interpreting data from medical devices. These might be visual data, and often are, and then are analyzed by computational tools. And these are important because the physician who gets a report from these kinds of programs often can look at the primary data set and decide if it makes sense to them that this interpretation goes with that image. So just, you can imagine that decision-specific clinical data uh, from a measurement device, and then software that produces an interpretive report, and then the report gets delivered to the clinician, either on paper or by computer. And things like electrocardiograms, EEGs, radiologic images, microscopic images, photographs of skin lesions. These are all examples of this kind of data that can be interpreted using computational software, much of it in these days AI derived. So the clinician verifies the interpretation and incorporates it into their decision making after they feel comfortable with the report. Maybe they follow it blindly, but in general, they like to just convince themselves that the report makes sense. It's key that that's possible because the issue of explanation becomes a little less vivid in these settings. Although oftentimes, if you are surprised by what's on a report, you'd like to be able to get explanatory information. Years ago, before AI was even very involved, I can remember when we had EKGs that would look like this, that could come out of a machine at the bedside. And at the top, they would interpret the EKG and tell you what it's likely to be. But we all, as medical students and residents and physicians, learned how to read EKGs, and we could look at that and say, do we agree with that interpretation? Usually we did, and if we did, we would go along with that guidance. And 30 years after that, we were beginning to see similar kinds of work with radiologic images. These are or photographic images. This is an early article that really showed in the Journal of the American Medical Association how a deep learning system really could interpret and help you understand diabetic retinopathy and related eye disease from retinal images that it had analyzed. And today we see this is a couple years ago, but it makes it clear that AI systems can often do as well as physicians in certain screening tasks and data interpretation tasks of the sort we're describing. So what's the second category? Well, this is the simplest, actually. This is what I call just simple event monitoring and generation of alerts for clinicians. Usually these occur in electronic health record environments, and they involve the simple logic that a clinician can quickly interpret. So, for example, suppose you have an EHR with patient data in it, and that EHR, of course, has to have some kind of an interface for the clinician to use for chart review, entering orders, and reaching decisions. So the clinician interacts with an interface that lets them see the EHR. But most EHRs also have some kind of monitoring software that watches what's going on in the EHR, and then is guided by a knowledge base of what to watch for, often written as simple rules. And if the event monitoring software sees a situation in the repository that warrants being brought to the attention of the clinician, it simply has a way of interacting with the interface so that the clinician, while they're reviewing the chart and the like, gets some of these warnings and alerts. An obvious one is, hey, you're about to prescribe a medication to which the patient is allergic. Don't do that. Here's a slightly more complex example of these kinds of rules. If a patient is receiving the drug digoxin and they have a low potassium, you probably should replace the potassium with an infusion or pills before you give the digoxin, because of the toxicity of digoxin that can occur in people that don't have enough potassium in their system. But it's a simple rule, and it generates advice, and the physician can decide what to do based on that recommendation that it receives. There are many examples like this. Essentially, all EHR systems use this. I wouldn't call this AI really in general. These are very, very simple rules, but they do play an important role in decision support. The one we've tended to focus on in the medical AI world is direct consultation with a clinical user, typically with a physician or other health professional. And this is where we've had the biggest challenges in gaining acceptance and demonstrating utility. When we first started working on systems like Mycin, the tool was designed to help with diagnosis or treatment. And it used some kind of analytical method, rules, in our case, scoring functions, maybe something statistical. And the clinician would interact with that. Now, in 1975, if you wanted to use such a program, you had to sit down at a computer terminal and describe your patient in response to questions from the computer. And over time, you had to have a very high motivation to go and do that in a busy clinical day. But over time, the physicians started saying, this program maybe is helpful, but why are you asking me for questions that I know are in the medical record, answers to which are in the medical record? Why don't you simply get the data from the record? That makes sense. We have this EHR, so maybe half the questions or all the questions could be answered simply from the EHR, with only some maybe having to be answered by the clinician. But remember, the EHR has this interface to clinicians anyway, so why do they have a separate interface to an advisory tool? They could just do it as part of their interaction with the chart and the electronic health record. So that's where maybe these kinds of tools should be generating their advice to the clinician who's using the device anyway and wants the data from the record to be automatically available to the decision support system. Although this is how the early work was done, this became known as the Greek Oracle model, where you had to go to the Greek Oracle and ask a question and get a response and do it all on your own. Whereas the tightly integrated model down here is much more acceptable. So this is what we normally think about today when we talk about decision support systems and the use of AI in decision support. But there are a bunch of issues that need to be taken seriously. And I'm going to quickly go through those as I finish up this talk. First, I still believe that black boxes are unacceptable, that people need to have a sense of why before they're going, why a given decision or recommendation has been generated before they're going to want to necessarily just follow it. By the way, this and the other points I'm about to make are all written up in an article that I published with a colleague back in 2018 in the Journal of the American Medical Association. It's just a small article that goes through key issues for clinical decision support acceptance. The issue of explanation is important outside of medicine too. The DARPA, the Advanced Research Projects Agency of the Department of Defense, has a whole sub-project on explainable artificial intelligence in the world of machine learning, which is so dominant these days. How then do you generate explanations from a machine learning system that basically figured out what was going on by scores on nodes in a neural network? So from this page, this is their web page for this work. Machine learning models are opaque, non-intuitive, and difficult for people to understand. It's a real problem for the machine learning approach if you believe that explanations become mandatory. And so you'll see some of the text that I took from this website, just so you get a feel for the fact that this is being taken seriously, even outside of medicine, as a requirement for many of these systems. I do want to acknowledge that this question of explanation has some counter arguments that have become more clear over time. There are innovations where there really isn't a logical explanation because no human expert can do the same task. So trying to explain how you did it, it may not be particularly helpful. And demonstrably accurate analyses can lead to trust in an AI system and acceptance of its use even without explanations. So what do I mean by that? The best example I've thought of outside of medicine is the use of intelligent vehicles that even function as taxis in some cities now, certainly in the United States and a few other countries as well. And if you use an app on your phone to call an intelligent taxi and it comes and picks you up and it takes you to the airport or to the restaurant that you want to go to, that is a little AI box you're inside. It's doing visual and location processing of all sorts. It's looking at traffic lights. It's looking at other vehicles. It's watching for pedestrians. It's doing things that have to be done. And at some point, if you do a lot of these rides, you become quite convinced that this is a pretty safe thing to do. They have excellent safety records. And so you're not asking for explanations of every left and right turn or that kind of thing. You just get in and you take it for granted that it will get you someplace safely. Now ask yourself how many situations there are in medicine that might be comparable. And is there a chance that you'd see such good data about a given program's abilities to be accurate that you would feel comfortable just blindly accepting whatever it says, even without an explanation? I think that's much harder for us to imagine, but there may be settings, especially in the future, where that becomes reasonable to consider. It's something we could debate. So what are the other ones besides explanation? Well, so if these systems aren't efficient, if they require a whole lot of time on the part of the clinician, they just walk away. They don't have time for that. So you have to really understand the workflow of a busy clinical environment and be sure that these kind of tools are incorporated in ways that are likely to be acceptable and tightly integrated. They have to be usable, intuitive, simple to learn. If you have to go take a 4-hour course in the hospital cafeteria before you can use something, you don't want to do it. And it should be pretty intuitive. And most software these days recognizes that requirement. I have to reflect an understanding of the pertinent domain and the likely needs of users. All you need is for a program who's discussing a male patient with you suddenly to ask if the patient is pregnant, and you say, this computer doesn't understand the world. There's something clearly flawed here, and it would decrease your willingness to interact further. This one is an interesting one. I think it is important, and that is being respectful of the user's own expertise. These are highly educated people using these programs. They have a basis for their own impressions in a case, and they really need to be viewed as partners. I've seen drawings like this that I think really misrepresent what this kind of software is trying to do. That is the notion that the computer becomes the physician. So this is a bad concept to try to promote. Similarly, really outrageous diagrams such as this one, robotic surgeons without a physician interacting with the robot. We do robotic surgery, but it's not that kind of surgery. So this is not the kind of thing to be describing either. What I think is useful is the very notion that the physician partnered with a computer may often be able to make some better decisions than they can on their own. And that is certainly the model that radiologists have been using. They use computer interpretations all the time, but they do not feel that the answer is to replace them as much as to make them more informed when they make final decisions and recommendations, which is why radiologists still sign off on all X-ray reports. There's a variant of that which says, computers on their own can't do as well as computers that have that human involvement in filtering what they have to say and deciding whether it's appropriate in a given case. So this notion of respect for what the user is and knows seems to be a really crucial component. And then finally, you have to have rigorous peer-reviewed scientific evidence that establish the safety and validity and reproducibility and usability and reliability of these kinds of tools before you turn them loose on real people. I like to tell people that, look, there's a whole lot of work you can do in the laboratory when you're developing the system. You can prove that it gives vital advice. You can even prove it's usable with usability testing. You can try to make sure you demonstrate how it would integrate with workflow and exhibit the reliability and the validity of the core technologies that you're using. But eventually you have to do real world evaluation in the naturalistic environment. And the very first thing is acceptability to users. If they won't use it, there's no point in going further. They have to have found from all the work you did in the initial work in the laboratory that indeed this seems acceptable. They'd be willing to use it. Now, using it and changing their behavior or having an impact on their behavior, because they're two different things. And you have to ask the question, are they treating the patients differently? Are they making different decisions because they have this tool available to them? Is there any impact at all that makes it worth the investment in providing these kinds of tools? And then finally, the important question, which is how do these systems have an impact on the actual outcome for patients? And if that's positive, then you could say, is it worth the money? And so all of these seem to be important steps in a multi-step process. And frankly, too often these things are not done in as methodical a way as I'm trying to describe in this drawing. So today, we have an explosion of interest in AI broadly, and medical AI in particular, some confusion in terms. I've heard AI, machine learning, data analytics, and data science used essentially synonymously, and they really aren't all the same thing. People need to have a better understanding of just how they interact. The notion that machine learning is AI is clearly wrong, and I especially urge people to think beyond the machine learning component of AI when thinking about the ability of AI to solve problems that they're interested in. Deep learning seems to be too often viewed as the full solution these days. What does it really know when it's performing well? Is it knowledge? How should we address this explainability issue with machine learning programs? Can the LLMs do it? How should we best merge traditional knowledge representation for a domain with programs that use machine learning methods to solve problems in that domain? And I've been looking a lot for answers to that question, and I'll mention one approach in a minute. Many of the early challenges still persist that go beyond decision-making ability, all the integration, interoperability, and terminology, standardization, data ownership, who's in charge of the data, many others. So the epistemology of today's learning system, thinking it from a knowledge perspective. I was writing a textbook on AI in medicine. People who wrote the machine learning chapter kept talking about how the algorithm derived by a deep learning program was new knowledge, but they couldn't tell me what the knowledge was. It was just that the software was knowledge. I think that's a perturbed notion of what we mean by knowledge. It can't be conveyed to others. It can't be mimicked by others. And so we need to think about how do we turn what a deep learning program could do into something that's learnable and becomes what we would call knowledge. When is transparency important in seeking user acceptance and development of trust in an AI tool? When is it crucial that we have explanation? Are current efforts to explain machine learning analyses adequate? And do we need to rethink explanation approaches in light of what we can now see coming out of chatbots? And here, some of you may know about this notion of retrieval augmented generation in large language models, where instead of just using large data collections, they've overlaid the reasoning process in the LLM with formally constructed knowledge representation and terminologies, relationship among terms, among ideas, and leverage those in generating solutions, sometimes with significant improvement. So that kind of recognition that adding to machine learning the simultaneous incorporation of knowledge representation may be a crucial part of the future in our area. So I think there's some key lessons. You should ask when you're working in this area how you can leverage how human beings, and especially knowledge experts, solve the problem, and not just ignore that capability. You have to think about when transparency is important in seeking user acceptance and development of trust of an AI tool. Or do I need to generate explanations if I want this system to be used? Assess the new explanation approaches in light of the remarkable recent abilities of LLMs. Consider if there are situations in medicine where verifiability is more important than explainability. Maybe just developing faith in a tool may be a reasonable goal. And then recognize that decision-making is not the whole story. All these other issues, usability and workflow, representativeness, avoidance of bias, trust, ethics, and the like, are all important to consider. So I saw that this is 2024. Will AI ever live up to its hype? In other words, are we in for another AI winter? There's an interesting article that was published in the New York Times. And I think the bottom line is that we're not seeing any signs of an AI winter, and I think it's unlikely we will. We're going to see changes in how AI is used and viewed, but the notion that we're all going to stop investing in AI seems very unlikely anytime soon. So how can we best leverage human beings, and especially acknowledge experts and how they solve problems? Transparency is what leads to trust, and that's what leads to good partnerships. So I think we need to assure ongoing collaborative role for physicians and their expertise, and bring them in while addressing the issues of usability and workflow, patient variability, avoidance of bias, and ethical performance. And I think it's reasonable to perceive that the future is bright, but we're still in midstream, and that was one of my points. I went through all those things that developed between 1990 and 2026, and that list of items is immense, but we're still doing it. I saw this recent little IEEE alert on a new kind of number, the first POSIT-based processor core, which gave a 10,000 accuracy boost in calculations. I mean, how are things like that going to change the way we're doing things in the next 25 years or so? So be aware that everything we think is a given today is really just part of a process that is going to go through many changes. So that's the messages I wanted to get across today. Some of them may be controversial. I'm happy to discuss them. And so I will take away the screen and we go back and talk if you'd like.
So Ted, thanks a lot for this inspiring presentation here. So at first, I can say the first question arises here, so maybe we can discuss about this in first place. So the question would be, how do you see the growing amount of data from growing number of sensors in clinical or private use? So especially what kind of data we receive here from all those numerous numbers of sensors, and these data being processed in machine learning algorithms may lead to results or explanations in medicine we do not know yet. So new knowledge, what is gained by those data, and how do we have to accompany these steps to remain able to understand scientific findings and those accept AI decisions. So yeah, a big
Oh,
issue
is that
here.
all?
So
Okay.
yeah, that is the first question. So
That's quite a
interesting.
question. Uh, I mean, part of that question I hope I've addressed a little bit in the comments that I did make. Um, I'll go back to the data part of this. Okay, I acknowledge that we have so much more data than we used to have in a computable form. Of course, the mere fact that we have so much data not only presents us with opportunities, but also the need to be aware of the risks to people of having all this kind of medical data in shared settings, and how to protect uh, uh, individuals who are part of that, while at the same time taking advantage in good ways of the how their data can contribute. And the second is understanding the complexity of the differences among them, which may not be well characterized in the data we happen to be collecting. We always make decisions about what we're going to actually record, and the unrecorded things may in fact be really important and lead to oversimplistic assessment of large data sets. And so I just think it's almost like what we need is ongoing uh, precise awareness of what we're dealing with, and the potential weaknesses and challenges associated with them. Uh, and not just sort of blindly say, "Oh, I've got so much data. I got 5 million patient records here. I'm sure anything I get out of that is going to be statistically important," and the like. There's an awful lot wrapped up in the question you asked, but it at least gives you a starting point, maybe.
Thanks a lot here. So just to find the bridge between the your answer and the second question then, so perhaps I just have a little intermediate question here from
Sure.
my side, because I think in first place what you're telling is us that that right now we're recording, for example, in the HR, the type of data from the patient, what we want to know so far. So, but that question, what we record, is also evolving in some kind of way, since more we are just using more and more knowledge from also a rising field of medicine. So what kind of issue do you see here in these records? Because obviously we are tackling a moving target in the end, no?
So there are no simple solutions to the problem. A new test comes up. Suddenly you've got your last 5,000 patients do have that test result, but you didn't used to do it. So the people you'd like to compare them with in the past, you don't know what their test result would have been if it had been
Yeah.
done on them. How do you deal with that? Well, we've been dealing with that in medicine outside of AI for ages. You'd love to know what this test would have been in that patient you remember from 20 years ago if you only had that test. Okay, so part of this is what we learn as science evolves, and there's no simple solution. You end up having to use more restricted data sets where you do have to test, and if you can find correlations that let you believe you can reliably predict what the test would have shown in patients before the test was available, that's great, but that may not be feasible. And you end up, therefore, collecting more data on more patients going forward. I don't see a magic solution to that general problem.
Ah, sadly. Okay, so let's come up to the second question. How can we keep the interest in gaining human expertise and knowledge alive in coming generations if all medical knowledge may be available in AI tools?
All medical knowledge available in AI tools. I guess I've never believed that that's likely to happen because new knowledge is being generated all the time. That's what in the investigation of both clinical and basic science does is generate the new stuff. And when you generate these new relationships and new concepts and new understandings, that's not in the database, and so you're having to start collecting it and move forward with that new information. So I just think that's always been a nature of science. You get new scientific understanding, and you can hypothesize how you could have applied it in the past, but the real emphasis is on how can I apply it in the future so that we do even better with future patients.
Mm-hmm. Okay, thanks a lot. So the next question would be, thank you very much for the talk. You showed some slides a lot about the black box and explainability, and you showed some possible solutions. What do you think about the superordinate black box corporations are calling? So there is not only a technical black box, but also one which is caused by the idea of the intellectual property, competition, or just marketing, which is overrates potential benefits of advertised CDSS. So yeah, a big issue here. So black box from
Do I
everywhere.
really want to explain if it means someone else can duplicate what I did? Is that what you mean? The basic
Yeah,
idea.
seems like. Yeah.
Explaining doesn't mean that you've given away all the details of the method you use to generate the explanation. And the method is what's really valuable. Okay.
Mm-hmm.
So I think these are, in a way, it's confounding or confusing two separate issues. One is how open you want to be about describing exactly how your program works, how your system works, or exactly how you're doing the analysis. In general, in the scientific world, we do that. We write it up. Maybe we copyright some aspect of it or protect it, so it's at least we own it. But the explanation piece that would be useful to a clinician should be a product of that science and should be offered because that's why you did it. You want people to have those kinds of explanations so that they're more persuaded and more likely to make the right kind of decisions for their patients. So I would hope we don't let competitiveness in the industrial sense get in the way of doing the right thing for patients.
Okay, thanks a lot here from your side. So we have another question, so which is more or less my sandbox here. So what is about the regulations? So thanks for the talk. If you were to take a look into your crystal ball and venture a guess, how will AI regulation in Europe, current example, the blocking of service like open evidence in the EU and UK, and in the United States, for example, the legislation in Colorado and potential soon in Texas ultimately play out, what in the end will actually remain usable within the approach of outlined, namely the trust emerges through use. So, yeah.
That was a whole bunch of stuff in one question.
I guess we can wrap it up in one thing. So the current barriers regarding the AI regulations in the whole world may lead to some troubles to come up with the routine care stuff in the end. And I mean, what is the right way to do so to say?
So the regulatory piece, I think, all has to do with protecting intellectual property and protecting patients, and both of those things need to be considered as important. The impact of this kind of work and the products that will be produced on the roles of individuals in the medical world. Are some specialties going to be more likely to be threatened by AI than others? For example, there are certain things you see in the medical world where you say, well, they use AI on the background sometimes, but what they're doing here, there's no computer that can do that. There's a lot of, especially procedural type things and stuff like that. So I think we all are seeing regulatory trials of various ideas that threaten the ability to promulgate the best of what we produce, and you want to try to be sure that regulation does not limit appropriate promulgation of ideas and tools. But on the other hand, you do want regulation that will protect individuals, both developers and patients, and that will generate a kind of ethical umbrella for how AI gets introduced into medical settings over time. I don't think we can say, well, we can't let anything happen that limits, that leads to the elimination of radiology as a medical specialty. That's one I've heard, for example. So we have to protect the radiologists at all costs. I don't think that's a reasonable thing to do any more than protecting guys that drive horse and buggies would have made sense when cars were being introduced. You know, that technology does change things in the world. On the other hand, I think, and I tried to stress this in the talk, there's a role for radiologists, even in a world where machine learning programs are doing a great job of image interpretation. I've seen some hospital CEOs say they're looking forward to the day that they don't need to hire any more radiologists. Mm-hmm. But then I've talked to radiologists who say, I'm so much better radiologist now because I have AI available to me. But I provide a value added that the computer alone cannot. And so I'm not sure there's a simple statement about regulation, given all the ways in which regulation could try to be wielded. It's needed, but it can be overdone. It can get in the way of progress, and we need to be sure that the right kinds of thinking goes into the regulatory decisions that are made.
Thanks a lot for the statement. I think the regulation is quite a hard job here to do, because the balance is the quite key here.
Yeah.
And I think just to raise some question here from my side, so before we are going through the next one, also the evaluation here is, I guess, the biggest issue. I mean, when we are talking today about ChatGPT and other large language models, also this kind of knowledge which lays here inside is quite hard to evaluate in the end, because you cannot write enough test cases to test everything. And so we are also issuing in some kind of regulation of this stuff, of course, in the end.
Well, we regulate through licensure physicians, and you can't test a physician on every case they might see.
Sadly not, no.
I mean, I think we deal with this problem even in a non-AI world, is I guess my point.
Yeah.
There are limits to what you can do from a regulatory and evaluation perspective. And you try to come up with ways of monitoring activities so that when new problems arise, you recognize them early and intercede as necessary. But you can't predict all of them. You can't imagine all the ways in which people might try to use ChatGPT. I mean, every day I hear something somebody is doing with ChatGPT that I say, are you kidding? You're doing that? uh, and it would never have occurred to me. So we're not gonna imagine all the ways in which they try to do some of this stuff until they happen, and then so regulation becomes a living thing. It has to evolve.
Yeah. So we will see how it will change also the whole societies in the world. So
Yeah,
we
yeah.
will see.